My name is Dr. Ajibola, and this morning we'll be talking about a very special topic, the cardiac manifestation of SLE, lupus heart disease. By definition, systemic lupus erythematosus is a chronic multisystemic inflammatory autoimmune disease and predominantly affects women in second to fourth decade, more common among the blacks, Asian, and Hispanic than the whites. Etiology. The etiology of SLE has been explained by both genetics and environmental triggers, and under genetics there are some SLE association, for instance SLE DR2, DR3, also complement deficiency, for instance like C2, C3 deficiency. Another explanation is also the environmental triggers, for instance like infections like EBV, estrogen, maybe that explains why it's more common in female, also medications, and then this group of medication they've been associated with drug-induced lupus, and there's a great mnemonic right there for them to remember these drugs: SHPEM, and the mnemonic stand for S stand for sulfur drugs, H stand for hydralazine, I for isoniazid, P for phenytoin, P for preconomide, E for etanercept, M for minocycline, and the last M for metidopa, which is alpha metidopa. And don't forget, remember, there's anytime we have what's called a drug-induced lupus, there's a particular antibody that we normally use, that we normally test for or check for in the serum to actually confirm the diagnosis. And anybody remember the antibody? Very good. So anti-histone antibody. So anti-histone antibody is what we use to confirm drug-induced lupus. And the last environmental trigger that we have on the slide there is also the UV light, which can also act as a trigger for SLE. So let's talk about the pathogenesis of SLE. So the pathogenesis of SLE has been explained by both type 3 and type 2 hypersensitivity reaction. And don't forget, guys, remember type 3 is the immune complex, whereby we have our antigen and antibody, and both antigen and antibody they combine together to form immune complex. And in this situation, our antigen is going to be our own DNA, and the antibody now is going to be our anti-DNA. So when both of them combine together, they form the immune complex, and they can take a trip to any part of the body. For instance, they can go to the kidney, they can go to the skin, they can go to the joint, they can go to the small vessels, or they can even go to the heart. And wherever they get to, they want to deposit there. And once they deposit, they activate the complement system. And then once they activate the complement system, they want to be production of C5a. And if you guys remember C5a is a neutrophil chemotactic, meaning that it invites neutrophil into the site of the deposition, and that is going to cause inflammation of those tissues. And just a quick question: what are the neutrophil chemotactics? Very good. So click P. So that's the mnemonic. Click P. And C stands for C5a, the leukotriene B4, which is LTB4, interleukin 8, K for kallikrein, and a P for platelet activating factor. And if you miss that, C is C5a, LTB4, interleukin 8, kallikrein, and a platelet activating factor. So the mnemonic that you can use to remember those chemotactic factor is click P. And also, like I said, the SLE is also explained by type 2 hypersensitivity reaction, which is antibody against the cell, and this may be against RBC, neutrophil, lymphocyte, and platelet, and this can lead to destruction of these cells, and that can lead to cytopenia. And there are there are different ways that this cell can be destroyed depending on which antibody we're talking about. Are we talking about IgG, immunoglobulin, or are we talking about IgM? And don't forget, remember, IgG is one of the opsins that we have, right? Remember, there are two major opsins that we have: the IgG and the C3b. And once the IgG coats the cell, what is going to happen? Then macrophage is going to take out those cells. Remember, macrophage has the ability to phagocytose, or maybe neutrophil, they can phagocytose and take out those cells and destroy them. And also, another way that we can also destroy them is if there's IgM on the cell. Remember, IgM is a potent activator of the complement system, so it can activate the complement all the way to MAC complex. And what's MAC? Membrane attack complex. Remember, that's our C5 to C9. And then once you activate once you produce the membrane attack complex, and down to destroy the cell, that can also lyse or destroy the cell. Also, another way whereby we can destroy these cells is both what's called both antibody, maybe the IgG or the IgM, also activating the complement system producing C3b, right? And the one thing I said earlier about C3b is also what? It's also an opsonine, right? So in other words, it's going to coat those cells and we want to destroy those cells, right? And that can lead to what's called the macrophage taking engulfing those cells and also destroying what's called those cells. And let's now talk about the lupus heart disease, the cardiac manifestation of lupus. The first one there is fibrinoid pericarditis. So fibrinoid pericarditis, and this may be with or without a pericardial effusion. And as a matter of fact, this is the most common cardiac finding that we see in SLE. And what's the classic presentation of pericarditis? So they need to be chest pain when they lie down, and then when they lean forward, the chest pain actually gets some relief, right? Because remember, when they lean forward, the pericardium actually moves away from the myocardium, thereby reducing the irritation, and that can reduce their chest pain. And it was the classic find that we can see on ECG for pericarditis, but we normally see that widespread, right? That diffuse ST elevation. So once you see diffuse ST elevation on the ECG, you might be thinking of pericarditis. And as a matter of fact, anytime you have, especially for the purpose of the board exam, anytime you have unexplained pericarditis or anytime you have unexplained pericardial effusion in a young female, make sure you rule out what's called and think of lupus, right? Think of SLE. That could be the diagnosis. And next cardiac manifestation that we see in patients with lupus is Libman sac endocarditis. And with Libman sac endocarditis, this is what's called verrucous white-like sterile vegetation that occur on both sides of the valve, right? Because it's an autoimmune process. So that's why the vegetation, you can see it on both sides of the valve. Remember, as opposed to the bacterial endocarditis, that one is only at one side of the valve, whereby the blood eats first. So that's where we see those vegetation. And this is a very sterile vegetation and they're often benign, but the thing about it is that it can lead to valvular heart disease, especially like mitral regurgitation. And the next lupus heart manifestation is myocarditis. And what's myocarditis? Remember, that's inflammation, right? Inflammation of the myocardium, right? And this has non-specific symptoms starting from patient can have tachypnea to shortness of breath, and they can also have sign of heart failure, right? Like what's called dyspnea on exertion, paroxysmal nocturnal dyspnea, right? They can complain of what's called dizziness. They can have what's called lower limb swelling. So these are non-specific. So a lot of what's called heart failure symptoms we can see with myocarditis. And the next lupus heart manifestation is congenital heart block. Congenital heart block. So this is a complete heart block in a newborn of lupus patients due to transplacental passage of anti-SSA. Remember, another name for anti-SSA antibody is also called the anti-Ro, right? Anti-SSA or anti-Ro. And then to the fetus and attacking the newborn heart conduction system. And this can lead to congenital heart block. So anytime you have a patient with lupus, anytime you have a child maybe that develop congenital heart block, make sure you rule out what's called the lupus in the mother, right? And don't forget, another sideline, another what's called the question that we can also encounter here is that don't forget that anti-SSA, which is anti-Ro, is not only seen in lupus, it's actually you can also see it in what's called in another pathology. You remember that pathology? Very good, guys. Sjogren syndrome. Remember, in Sjogren syndrome, we also see what's called the anti-SSA, right? Remember, anti-SSA, anti-SSB, both of them they are seen in what's called in Sjogren syndrome. Remember, Sjogren is what's called the autoimmune destruction of what's called the salivary gland and the lacrimal gland, right? And then the another name for anti-SSA, like we said, is anti-Ro, and another name for anti-SSB is anti-LAR, right? And the last lupus heart manifestation that we have here is coronary artery disease. So lupus can also affect the coronary artery and thereby leading to what's called ischemic heart disease, right? And these are what's called the lupus manifestation, the lupus heart manifestation or the cardiac manifestation of lupus. Thank you guys for watching my video this morning, and don't forget to subscribe to my channel.